closely with this past year, who will give a presentation titled Bridging the Gap, Recommendations for Effective Communication Among Midwives and OBs. And first, just a second. I'm starting to record.
Oh, we did it.
Okay. So first, I would like to take a few moments to introduce Char'Lee, who is a full spectrum doula and a student midwife with years of experience working with youth in a community-based programs and in healthcare settings as a practice manager specializing in LGBTQ+ reproductive health. In those roles, Char'Lee has helped increase family engagement alongside community-based organizations and health centers by providing them with resources to make informed decisions about their health. She believes that creating new systems that are rooted in the community needs, anti-racism, shared decision-making, and that are collaborative will help address the inequities that she sees Black birthing people experience. Char'Lee, you have the stage.
Hey y'all, so my presentation is titled Bridging the Gap, Recommendations for Effective Communication Amongst Midwives and OBs. I do want to apologize in advance because I'm a sex educator, so I'm going to use all of the skills and toolboxes that I learned to make sure that you all understand the scope of my research study. So what was my inspiration for this project? I became a student midwife last year in East Texas, which is not like big Dallas or Houston. And we were having all of these transfers and coming into those hospital systems, providers were a little standoffish. Yes, sorry, go ahead. The camera's off from lunchtime. Oh, the camera's off.
Oh, it says it's on. But it's not looking at you. Okay. Can you see it? Can anyone see it? It's good. It says it's working.
It's fine. I'm here. I'm here. It's alive and well. And the providers were a little standoffish, or they were angry for whatever reason. Like, why did you wait so late? Or why is this? Why did we end up here when they could have just had a hospital birth? So I really wanted to dive in deep to figure out what was the issue. And what were the facilitators and barriers to being able to collaborate and communicate effectively? So when I started this project, the Joint Commission published all of this research, and it was saying that the #1 cause for adverse health outcomes was lack of communication. And that should be a simple fix. I don't need money to talk, right? We do it all the time. And I wanted to create opportunities for perinatal providers to learn about each other's work. As a practice manager, I work with providers and nurses. And then as a student midwife, I work with CPMs, CNMs, all of that above. But my worlds were never really colliding. So I wanted an opportunity to show folks all of the wonderful things that I get to experience working with all of the different folks. And we just wanted to recognize the systematic challenges that providers face in out-of-hospital transfers in emergency situations. All right, next slide. Do I just click it? So what's the problem? Essentially, I set out to figure out what was impeding effective communication amongst perinatal providers and what was helping providers communicate and collaborate effectively. Okay, that's backwards. So my specific aims for this project was I had to conduct a literature review, recruit and hold 1 to 5 focus groups. Based on the results I received from the focus groups and findings from the literature review, create a model for interprofessional communication, and then create a short description of the model outlining how hospitals, clinics, and birthing centers and midwives, whether they were birth center midwives or home birth midwives, could utilize it. Throughout the literature review, really, these were like the overarching things that kept coming up, right? So poor communication was the number one reason for adverse health outcomes in hospital settings, right? Providers are trained within their respective departments, and there's really no opportunity for them to collaborate or communicate with other professions until they start working in their respective settings, whether that's a hospital, an ambulatory clinic, or a birthing center. And then historically, there has been tension amongst providers and their respective governing organizations or school messaging about other perinatal providers, right? So midwives will say things about physicians, physicians will say things about midwives, and we kind of can see over time how that played out with them having a hard time figuring out each other's scope and figuring out how to work together effectively to care for patients. So my literature review was really, I found like most of my research using PubMed, Google Scholar. I use key search terms like barriers, communication, interprofessional collaboration, sometimes all of the words all together, sometimes none of them together, right? So trying to really get at what we were working with. I got an opportunity to conduct a mixed method study with 2 focus groups. And we used a case study as well as a survey, a pre and post survey, to really get at their experience with collaborating. I transcribed the focus groups material and categorized the findings into themes. And then I utilized the findings from the discussion group to create the model for interprofessional communication. And then from that model, I created a guide to show folks how to use it. So the case study is what it is, right? So it was a 35-year-old patient who had to be transferred to the hospital due to failure to progress. Her water had been broken for 36 hours up until that point. She had no signs of infections, but she did have a few instances of elevated BP or high blood pressure. And the focus group participants had to come together and say, like, what is the plan of action now that this person is in the hospital system? And who does that plan of action include? And how do we get to a consensus amongst all of us? After they did that case study, I asked the participants questions about the facilitators and barriers to collaboration and communication during the case study, but also asked them questions about those same things, but from their previous experience being midwives, doctors, doulas, etc. And then I asked them what resources do they think could help facilitate collaboration and communication amongst perinatal providers. So the pre and post survey used a Likert scale, which one being they strongly disagree with them being able to do anything as it related to collaboration and communication interprofessionally, and 7 meaning they had it down packed, right? They were ready to go communicate with a physician at the next transfer they received. So the survey questions were kind of like, I'm able to promote effective communication amongst members of interprofessional teams, or I'm able to seek out interprofessional team members to address issues. And then they were able to say, yes, I agree, I can definitely do this. So they will rate themselves a 7, or they go say, actually, I don't know if this is how this works. So maybe I'll rate it like a 2. We'll go to the next stage. Very fortunate enough to be able to host 2 focus groups that consisted of 6 participants. The participants self-identified as females between the ages of 26 to 59. The participants' years of working as a perinatal provider range from 3 years to 30 years, with experience without a hospital transfer ranging from 0 to 50 incidents, right? So a whole wealth of knowledge was presented within that group. 3 of the participants were certified nurse midwives. 1 was a certified professional midwife, and 1 was an OB/GYN resident / doula, and 1 was a doula. At the bottom of their this social demographic survey, We wanted to just see if their professional philosophy, values, or theoretical perspectives influenced their ability to collaborate. 4 of them stated it was greatly influenced, and 2 of them stated it somewhat influenced their behavior to collaborate. So here are the results. When we first started, this is before even folks even talked to each other, folks were ranging between, the lowest was a 4.84 and the highest person rated at a 6.53. So we had someone who was in there like, I could probably do it, but I'm not really sure about how this works. And then we had other folks to be like, okay, I've done it. So I have a couple skills, but I could like fine tune those a little bit. It's kind of what those numbers are saying to us. After we did the case study, we did a post test. And as you can see, the numbers increased drastically, right? They felt like they had the tools that they needed to be at least be able to seek out other members of the perinatal providers to talk about what went well or what did not go well, right? So there's 2 numbers here missing. So when we designed the Google form, we weren't able to match up the 2 CNMs in the second group based off of the results. So we just left out their information, and we'll talk about that in the limitation portion of this. So what did I find? The barriers really got at the lack of trust amongst perinatal providers, especially the relationship between midwives and doctors. Midwives were not given the opportunity to give report to providers. So they would bring their folks in for a transfer, and providers will act like they have to start over from scratch, ignoring all of the work the midwives had done up until that point, right? And some hospitals and clinics just straight up refuse to collaborate on care. And once that person transferred into the clinic, the midwife was no longer a part of that scenario. Some of those facilitators was that all perinatal providers being willing to participate, right? So the midwives being willing to talk to the doctors, and the doctors being willing to talk to the nurses, and like everybody is a part of that collaborative care model. The midwives being seen as trusted and capable providers. Sometimes we get the notion, especially when we're talking about traditional midwives or CPMs, is that, oh, they're not really providers. And it's like, no, they are providers. And for them to be treated with respect and being looked at as capable of doing their job well is extremely important to making sure that this working relationship goes well. And then the opportunities to build rapport with perinatal providers, right? So creating intentional spaces to learn about each other's scope of work, to be able to say like, hey, this transfer situation was really hard. Let's talk about it and figure out what we can do the next time this occurs. And then what resources or support that they need. Some folks mentioned the Smooth Transition Program, which helps do some of this like communication and collaboration amongst systems. Also, we touched about this briefly, but the intentional debriefs of successes and challenges during transfers between midwives and physicians, and then the intentional settings to build rapport. So the same things that are great for facilitators are the same things that folks need support in creating those environments. So let's talk about King's interprofessional communication model, right? So we really wanted it to be rooted in community. And we really I thought about what this actually looks like in real life, right? So this is just like any other relationship that you enter. You don't want to do all of the things at once, right? Like maybe you want to start with trust. How do we start with trust? Well, you got to know their names. You got to know who are the players, right? So maybe, if we set up an intentional meet and greet, we start with, what do you do? How do you work? What is your role? And then you kind of learn about each other. And then you say, oh, great, I'm from the midwifery clinic behind the hospital. And this is what I do. Come and see what we do at our clinic too. And then you kind of like build up that relationship, right? And making sure that the communication is respectful on both sides. Now, the system has to play a greater role in this relationship because as we're building rapport and doing that intentional relationship bonding, we really need the hospital policies to support that, right? We can't have hospital policies to say, oh, we don't support home birth clients. Like, that's not helpful. There's a place and a space for everybody to give birth. So how do we work together to make sure that people are supported and they're safe, right? So we need hospital administrators to help aid those policies and be intentional about creating those policies so that midwives and physicians and nurses and doulas all can work together to really improve maternal child health outcomes. We need intentional opportunities for connection, right? So maybe it's a quarterly meeting to just say like, hey, I'm a new provider in the area, or I've been a provider in the area for forever. Why don't we come and like either meet up at the birth center or meet up at a park and let's get to know each other. Let's talk, let's do the things. And we need more training for providers in the hospital system to learn about the benefits and the processes of normal physiological birth, right? So a lot of hospital providers and also in the research, a lot of like nurse midwives, like I didn't get the opportunity to learn about a non-hospital birth until I sought out the opportunity. It wasn't something that was just presented to me. So I didn't know that there was all of these ticks and trips, or I didn't know what midwives really did until I actually was in that environment. So the more that we can learn about each other's roles and how that operate in different environments, the easier it is to have these conversations. And we get to dispel myths also. So what could this look like? During an emergency transfer, a midwife should be able to contact the charge nurse and fax over the medical records. The RN gets report from the midwife and prepares for the incoming emergency transfer. Upon arriving at the hospital, the midwife, the patient, and the receiving care team cover any questions that the patient may have or that the receiving care team may have that was not covered in those faxes or during the report that the midwife gave the RN. After everybody got all of the information, the receiving care team and the midwife, can go over a couple of the questions presented back to the patient and to allow the patient to ask questions and to get consent to move forward. And then the midwife and the receiving care team should debrief the transfer to discuss the success and challenges, right? We want everybody to be a part of this. We don't want to leave out the patient because the patient really is a huge part in all of it and is affected by folks not being able to communicate or collaborate effectively. And we want the midwife there and being a part of those conversations because they have a valid perspective and they have worked and built rapport with the patient since the start of their prenatal care. The discussion, right? So really after the focus groups, it really brought attention to these themes, right? So like perinatal providers have better experiences with interprofessional collaboration and communication when they've established relationships prior to transfer. I feel like I've been saying that since I started talking to you all a couple minutes ago, right? We do better when we know the people that we're working with, when we trust the people that we're working with, right? The literature says it, the focus group says it, they all telling the truth here somewhere, right? There's proof in the pudding, people. And effective interprofessional collaboration and communication amongst providers work better in systems that they have support of healthcare administrators. The people who are writing the policies and pushing forth the policies also have to be on the same page as the providers that are in the system working it, right? And that the lack of trust and open communication is a barrier to effective collaboration and communication. I really spent a lot of time researching the effects of poor communication at emergency transfers from out of hospital settings, right? And in that research, it's not much, it's like a couple articles, but in that research, it really did the patient a disservice when the midwives weren't able to give report. And when the providers didn't trust that the midwives did everything that they could possibly do before they ended up in that situation. So it has to come from both ends. And the midwives also have to trust the providers, that the providers are going to take good care of their clients like they take good care of their clients, so we don't have any delays in transferring during an emergency situation. So what are the strengths? The results of this research study were very promising, and they're consistent with the literature review. There were different providers. We had a physician, we had CNMs, we had a CPM, we had doulas. There was represented in the focus group. And the data that was generated was both qualitative and quantitative to help capture the perspectives and evaluate the impact of the workshop on the participating providers' ability to engage in interprofessional collaboration. The limitations, focus group recruitment. Recruitment was hard. I'm not gonna lie to y'all. People was like, yes, you're doing great work. I want to work with you. And then the time it came for them to actually do the work, they're like, oh, but it's a liability. Or, oh, what does this actually mean? I wasn't really ready. Like, I'm happy that you're doing the work, but I wasn't really to help you to do the work, right? So right before we got to implementation stage, 2 of the hospital systems that we were in communication with pulled out. And they're like, we don't want our providers on that level of like, basically like judgment, right? We don't want them to feel pressured to do this. And because of that, it's a liability concern. Or the providers didn't actually work for the hospital. They worked for a hospitalist group. So they were coming in to just do deliveries. In the focus group with the physician, she also was a full spectrum doula before becoming a provider, right? So her experiences and her willingness to collaborate came from her experience as a doula, helping folks and being able to witness some of the things that were going on between providers and other, or physicians and other providers coming in. So she was more willing to participate and had a different perspective because she had saw home births before. She saw hospital births in the births, things of that nature. And then we could not match up the pre and post test results for the CNM participants, just due to them. We did a Google form, and in the Google form, there wasn't like a second identifier to be able to match up the 2. So we left out those 2 results in the finding. And then one of the focus groups included participants from different geographical locations. So they experience different barriers to being able to collaborate with their providers based off of their where they were working, right? So we had providers from Washington State. They're like, oh, it's great. We love it here. Like we get to communicate and collaborate with hospital systems, right? And then we have folks from Texas being like, collaborate with who, where, what? So being able to talk to them about those experiences and figure out what works well in different places was insightful, but it also didn't get to capture at least one geographical location. Recommendations for future research. I would hope that someone could replicate this research with perinatal providers working in the same community to ensure that the study findings were right? That everything was in alignment, because that word is not coming out of my mouth, y'all. For interprofessional collaboration and communication in individual community settings, and focus on the perceptions of providers and hospital clinic leadership about out-of-hospital births to examine how that affects patient outcomes, right? So, and then secondly, is to focus on the perceptions of out-of-hospital providers about hospitals within the system to examine how that affects the transfer, right? So we need to look at the perceptions of the hospital administrators to figure out what are their willingness or their determination to change the policies and what is preventing them from doing so, right? And how those policies affect the outcomes of transfer patients. But then we also need to look at the perceptions of the providers actually doing those transfers to see if their perceptions impact the outcomes of those clients, right? And before we get into questions, I do want to do some acknowledgements. So yeah. So this has been a long journey. I want to thank Tanya, because without her, I would not be here. I was not a good undergrad student, and I felt like I did not have the ability to show the brightness that I have, right? And she gave me the opportunity to be a part of this program and believed in me to the very end, right? Like, I was ignoring her emails. She called me like, sis, are you ignoring me? Like, we need to get you to finish this degree. To Kristen, for sending me all of the endless research and like always thinking about me. Also texting me and hounding me down when I did not want to talk to you either. Yeah, right. I'm an avoiding person. So I do appreciate that. So Christina, who's like, everybody needs a Christina in their life. She is a personal cheerleader. Even when I would send her something, I'm like, I know this sucks. And then she'll send it back like, it was great. And I was like, yeah, but my whole paper is in red marks. Like, what do you mean? I do appreciate that. Also to Wendy for also sending me a lot of good gems that I got to use throughout my research paper. And I am truly grateful to my family and friends that supported me this year. Has been upside down, right side up. So I do appreciate their love and support, and to just everything. To my cohort members for hearing me complain, or when I miss an assignment, be like, hey, how did I miss that? Can somebody help me fill in the details? And truly to Anna for advocating for us on every end of the spectrum. When we did miss deadlines as a cohort, to make sure that we were on track. So I appreciate and love and thank you, and thank everybody who is joining virtually to listen to me talk. Now, any questions? Oh, Amber's online. Hi, Amber. We miss you. Any questions?
I'm curious, I didn't totally catch like the implementation and how that happened. Like, was the implementation the focus group? And then like how, one of the things I was curious about, like when you're talking about your conversation model, like how, and like an ideal world, like how would you make space for that? Because like there's so much of like, we're too busy, like, or lack of interest. Like how would in the dream world, like how would you actually like implement that so that folks were like participating in it?
Yeah, so the implementation of this happened it was a lot of moving pieces all at the same time, right? So people decided to join the focus group, which was about 90 minutes long. And during the focus group, they did a pre-test or a pre-survey just to see like where they were with interprofessional communication. And then after that, we was like, all right, we move into the next stage, which was the case study. So the same case study that I presented here is the one that they got. And I was like, this is all the information you get. Good luck. I'll be back in 45 minutes. And then they assume roles. So, some people decided to be the physician, somebody decided to be the doula, somebody decided to be the doctor, like, or the midwife. And then they walk through care plans for this patient. And then after the 45 minutes, I went back and was like, all right, so what's the plan? And normally the person who assumed the role of the provider is the one who gave the plan. And I was like, okay, well, let's talk about it. So then everybody pushed in. I was like, yeah, we all gave our ideas. We all did the things. But even in a setting full of midwives, in most cases, it still was assumed that the provider had to be the one to tell me what the care plan was for the patient. And then after that, I asked them some questions. I had an interview guide. So it really was like, what worked well in this case study? What didn't work well in the case study? They all said they needed more information, which makes sense, right? Because you want to get a glimpse in a case study. But what worked well for them was that they were able to share their perspectives without judgment. So they felt like they were a contributing member to this care team, even though they weren't the person that was technically caring for that patient in that second, right? And then after we talked all of the questions. We also asked about the resources that they would need to like do the work. And then after that, they did a post survey. They mimicked the pre-survey to see if their knowledge increased, right? Or if they were more willing to participate in interprofessional collaboration.
Maybe it's not clear though, when she said King's interprofessional model, she means Char'Lee King.
Yeah.
She made that, okay, just that model, like a model is also part of what she.
No, yeah, I know
Right,
that.
okay.
What I was asking was like in like actual practice, like you're a midwife, someone else is a provider, like how do you like implement that in practice, not in like the focus group or whatever?
Yeah, and so with my experience as being a healthcare administrator, we get a lot of policies that we shift through because we're like, okay, what makes sense logically, right? And when we're looking at those things from at least a healthcare administrator point of view, we're looking to see, is this safe? Is it effective? Does it save me money?
Right.
Sometimes it's, does it save me money? Is it safe? Is this effective, right? And for the providers that are entering that system, if as a healthcare administrator, I'm setting the tone to be like, okay, home births happen and they're safe, but sometimes things happen and people got to transfer in the system. So let's make sure that we have things in place to support those families and to include the midwives. And it saves them money, right? Adverse outcomes are very costly for hospitals. Adverse outcomes are very costly. Now, and we lose a human life sometimes, right? That is the ultimate cost that a lack of communication brings. So yeah, we are busy, but if we do the work on the back end to make sure those systems are in place, then all these other things come a little easier, right? So like if we create opportunities for hospitals to say like, hey, come in, the local midwives come in and let's eat crackers and talk about what's going on in the community, which y'all seeing during your births. And then we do the same thing, that's great. And if the midwives are inviting the hospital providers to come out to their birthing centers or to meet and greet at the park if they're home birth providers at our office space, then they build that relationship. So then those policies don't seem hard, right? It's just like any relationship. When we first meet people, I'm not trying to give you all my information. I don't know you. And why do I trust you? I don't have a reason to, right? So if we're meeting at a transfer situation, there's nothing to go off of, right?
So you're talking about like building the relationship.
Yes.
On the front end. And then I was curious, like like it sounds like you're talking about like two things, like building the relationships and then also potentially like getting buy-in from hospital systems so that they present that as like a professional development, like that communication model.
Yes. Really, if we want to get to it, we really should start at education systems, right? Yeah. So like nursing school, midwifery schools, doctor schools, medical schools, there it is, should have a course, right? They should have a course to simulate some of this and to talk about it so that when we do those, those simulated events, we simulate it with all of the students and then say like, oh, your communication could have been a little better right here, right? Or maybe we should think about this when we go into the hospital settings.
Something like locally, I remember Karen was talking about that in one of an advocacy class, that there was some midwife that was going into some like medical school or something.
Yeah, school transitions. Is
that what she said? Okay. Oh, okay.
Yeah.
That's so cool. Well,
and actually the Department of Washington State Department of Health is trying to institute a model across the state.
Oh, okay. That's so cool. I mean, I just like if you can like get the buy-in, or if you could like I feel like there needs to be like so much buy-in, and but it's hard to get the buy-in, so if you can have that like you're saying, like front loaded, like in education and professional development, then it's like, this is what we do, right? It's not just like, if you like it, we do it,
Yeah, that makes sense. Tanya?
I'm really looking forward to reading the paper and the literature review, just saying. Because I think it's gonna be important, that we have that out there. So my question is, when you were analyzing your post-test, your pre and post-test unit comparison, were there things that you wish you had asked? Like when you look back and it's like, oh, I wish I had asked this question.
Yeah, I wish I would have asked where they were from, right? Especially when we're talking about like CPMs, the climates are different in so many of the states that it's kind of hard to figure out what's the best model of care. Because, and I think that was like the motivation behind the model I came up with, is that no matter where you are, you can like pick a couple of these and try them out. And I feel like some of the other models that I had seen were very location specific. So I wish I would have asked them what location they were at. And then I also wish that there would have been more opportunity to really dive into their experiences with transfers. And I should have put this as a strength of, or like research, is to interview the patients that were a part of transfer situations to see how they felt watching sometimes the cluster mess that occurs during a transfer situation. Yes.
Obviously as a patient, but also like I just remember some really horrific transfers as a doula, like watching the interaction and watching like the incredible like midwife that you respect, and then going into like a hospital setting where the doctor is just like, you're nothing.
Yeah, that's hard. Christina.
So I just want to highlight the important results that you could see from even this like small amount of data that you collected in terms of how this simple intervention, right? Having people come together and working through a fictional case scenario can improve their openness and their perceived skills to engage in interprofessional communication. And you made a very good point earlier when you talked about how we should have such problem-based learning, curriculum development in all the programs preparing healthcare professionals. But once people are, out of that space, of the educational space, how do we ensure that people who are already working have access to that kind of productive interaction? What may be the role of leadership of healthcare facilities in that?
Yeah, I think so hospital systems, especially school-based like hospital systems, do M&Ms all the time. So some of that too could be addressing like what was the communication barriers that also led to this patient outcome. And also including interprofessional collaboration, like trainings, like there's not a ton, but enough trainings to go around to get folks started, to include that into competencies with like entering the system, right? And then evaluating those every so often. But I think that it needs to, when we talk about adverse outcomes for patients, we also need to talk about how do we communicate together as a team and what could have went better. In a way that is larger than like the quick little debriefs that we have at huddles when something happens, but really examining what system failed this patient. I like systems work, so
Yeah.
it's a thing. Yeah.
I just thought I would, I didn't know if you saw Ann Smolsky. I don't know if if you want to invite her to unmute, but she had a great question that Dr. Del Villar seconded. Do you want to ask Ann if she wants to unmute, or I can?
And hi, they want to put you on spot.
Only if she wants.
If you want to uplift your comment that you put in the chat. I don't know if she's still here. I don't see her.
Okay. Well, it was, can she talk you into presenting about this with some partners?
Yeah, she pays me, so I definitely will do whatever she needs me to do.
Excellent.
But if anybody else wants me to talk to partners for them, of course, I'm always down to support and figure out how we can make better systems to improve birthing outcomes, especially for Black and Brown birthing people. Any more questions?
I know that we both like got to hear Mama Hakima come talk with our class, but I know you also talked to her like for your interview, and I know learning about her clinic was so incredible. And I know that's a different care model than what you're talking about, but I wonder if there were more clinics like hers where there was so much just within her space, like collaboration between those providers. And I know that they talked about having those like debriefs at the end of the day and just talking about a client, that I wonder if some of those clients that maybe ended up having to have transfers, or I don't know if there's any sort of plan for that, like inviting other providers in the community to kind of.
Yeah, so I know in Washington State, she actually was my chair, or not my chair, but my subcommittee member, Jody Glenn Owens at Rainier Valley. She actually has a collaborative model with providers, right? But even her journey to get that far was like, you know, them sneaking a talk behind the scenes, right? And then eventually somebody believed and trusted her so much to be able to build out this larger scale model that's working really well. So there are clinics that are doing the work. They're just doing it in silos and like quietly, right? And then it also depends on geographical location. Like, is the location you in, are they supportive of midwives? Are they supportive of home births, right? So I think there is an opportunity, and I think, you know, smooth transition started, you know, the conversation, but really honing in on some of these systematic like policy changes is super important. So yeah, I think there's room for it.
I just really love that you did the case study like that. I never would have thought about that, like actually having to practice it. But that's...
Yeah, when you are a student midwife, there are some things that traumatize you. I'm not gonna lie. And the case study was inspired by something that I actually went through, and I was like, oh, this is why I'm writing this paper, right? But I think it is important because as midwives, or, you know, as providers in general, I would hope we all want to give our best care. And we will want that folks have systems in places that no matter where they give birth, that they're safe and loved, and that people are respected across the board. So the case study was an interesting way to see how passionate people could get, even about like a made up character, to be like, I need her to have this, or why didn't we do this, right? And that all of that was respected. And no one was offended by any of the things. They just let it ebb and flow. So instead of saying no, they just said, and did we consider this? And then somebody else said something else, and it's like, and did we consider this? To guess.
Yeah, and I don't have like lots of questions, but I just wanted to say, like I've had experiences when I was working in Arizona of like this uncomfortable transfer experiences. And people work when there is like some sort of like a policy, mandating you to accept changes, and like this, for example, this transfer, and it goes to the licensure of CPMs too, because in states where there is like favorable laws and regulations around CPMs, like for example in Idaho, then you are required to like transfer your care properly, going into the hospital and presenting your case, and this is why she's here, and then the provider will accept. So it's mandatory, and then they should respect that thing. When it comes to like other places, then it's completely different. And even if we're accepting your patient, your client, then I don't know who you are, and I don't want to know what you've been doing so far. Even from the providers who were collaborating with us in Arizona, they're like, we don't care what you've been doing so far, and they take the client as someone who didn't have prenatal care at all. Yeah. But they are willing to take out. Clients. So there needs to be like just some sort of like a law regulation forcing them to talk to us in some way. In addition to our willingness to like communicate properly and collaborate.
Yeah, that notion came up actually during the focus group, right? And I think this is where policy has its place, right? We could create policies that outline some type sort of system, because I've been in transfer situations where you're right, you come in with a client and then they are running all the collab cultures and GBS swabs all over again. And it was like, but it's right here. So being able to take into account what has already been done and using that as valid evidence, right? Like we have healthcare record systems like everybody else. And we have to document vitals just like everybody else, is important. And I think that with some of those educational pieces and like learning about what the scope of work looks like for every provider can dismantle some of that fear or lack of trust that physicians are experiencing at those transfer situations. All right.
Thank you, Char'Lee. All right, well, thanks for everyone who joined for Char'Lee's awesome presentation. We we'll take a little 13-minute break here and we'll gather back here 2 p.m. Pacific time for our last but definitely not least presentation. So we do hope you'll stick around and come back in just a few minutes here. Thanks.